apparently he liked the idea, so here I am. We're going to talk about it a little bit. So here we go. My name is Stuart Cayer. I'm with Kelsey Seabold Clinic in Houston, Texas. I have been there for about 18 years. Prior to that, I was on the hospital side of things. In my previous job before coming to Kelsey, I was the chief operating officer of a small hospital in West Virginia. Again, I've been at Kelsey Seabold now for about 18 years. Love it. And working with physicians on the outpatient side now. But you know, for 32, 33 years, I've been working with physicians and helping out in many different ways. I do want to talk about our model just a little bit and how we may struggle with this. I think a lot of our physician leaders would say that we struggle with mentoring physicians, and we do. I think every organization probably does to some extent. And based on what I heard, you know, from the last presentation as well, this is an issue that we continue to work with and continue to grapple with, and we're probably not getting it right in every situation. We know we're not, but we're going to talk about it. Hopefully I can create some discussion around, you know, what a practice administrator can help with. And if that works, great. If it doesn't, well, we'll see, but let's go ahead and move on. Burnout, the inability to recover from the stress of the previous day. I'm about to show you a video. I hope it works. In this video, you're going to see what happens to burnout. It basically turns into a breakdown at times. Now, this video is a snippet from a movie, and some of you may have seen it. The character's false, obviously, but I think some of you have probably seen this movie before. And this is it's not an indictment on Epic or Obamacare or anything. It's just an idea, really, of what a physician may go through at times that may lead to burnout and breakdown. I actually use this video. One of my other jobs is I teach a class at the University of Houston in healthcare operations, both an undergraduate and graduate level course. And so I use this as an example to teach the students about what a physician goes through. It's not easy being a physician. At least, I'm not a physician. I'm not a clinician. I'm an administrator. But I see what happens. I see the stress that you go through. So hopefully this video will work. Or maybe it won't work.
Looks like it went off.
I don't think my video is going to work. It's right here. Files it on a stick. Or is it embedded? It's embedded. Well, we don't need to watch a video.
Well, I lost the slides too, though.
I do not.
We need a millennial.
We do need a millennial.
Get our millennial.
That's here.
They just have to breathe on it. They just right?
We have 600 IQ points at the podium right now.
That's the slide afterwards. All right, that's okay. We won't watch the video.
Is it a
Yeah, actually, I apologize. It was a link.
Okay, probably. Was it on a USB?
Yeah. That's okay. We won't watch the video. The video, anyway, goes through a physician having a breakdown because a lot, and every one of these things that you will see on this slide right here is something that the physician was going through. He complained about the Epic, about having no face-to-face time with patients. He discussed just being a cog in the wheel, about being basically at the whim of whatever bureaucratic agent was telling him how to chart and how to see patients. So we're going to move on a little bit. And I think we'll circle back around on some of these issues as well. So a little bit more about Kelsey-Seybold. We are a large multi-specialty group practice. Everybody here may not know who we are. We're Houston-based, the fourth largest city in America. We have roughly 420 physicians, plus or minus, on any given day. 20 different locations, soon to be 22. We're about 65% capitated, which tells you a little bit about our reimbursement structure. We've got a lot of competition in the area. And if you're in Houston, you know it takes an hour to get to Houston. I mean, it's not an easy city to get around in. Austin's much the same way. We just came back from Austin. And Dallas is huge too, but it is very difficult to get around. So I want to talk a little bit about our organizational structure. And there's a reason I want to do this. We have a medical director, you know, for these 420 physicians. He obviously takes care of a lot of different issues, from the most mundane to the most serious that we talked about here just this past presentation. But that's one person for 420 physicians. We have to highlight family medicine, Dr. Carter couldn't make it here this week, but we have one chief. We have no associate chiefs in family medicine. And we have roughly 65 physicians who see patients 7.5 hours a day. They get 30 minutes of charting time. I know a lot of groups get a lot less time for seeing patients, and actually some groups even see patients for 8 hours a day. But our physicians get 30 minutes of charting time, and it works out okay. It doesn't work out great, but it works out okay. We're at 16 different sites, and Dr. Carter visits them one time a year for 45 minutes. That's it. So that's not a lot of one-on-one time if you want to know the truth. In that 45-minute session, he's asking general life questions. What works well? What does not work well? What could you change if you could change it? But he gets a lot out of that 45-minute session. And one of the things that routinely comes back are operational issues, if you want to know the truth. A lot of it's about nurses. Hey, administration wants to fire my nurse, I like her. Or administration won't fire my nurse, I hate her. You know, it's on both ends of the spectrum. And I will tell you that when Dr. Carter has these visits, he typically comes back to meet with me and shares his thoughts on what's going on in the clinic. So he holds operations accountable in a lot of respects with how the culture really is moving and shaking in that specific site. And it's different from site to site, which I think is a testament to that a lot of it depends on your leadership at each site. So Matt talked a little bit about the dyad too. In each one of our clinics, we have a dyad with a physician manager or manager. Sometimes we have more than one, and then a clinic administrator. You know, that physician manager may have 10 to 30 plus providers. Actually, it's 35. I have one clinic in Sugar Land where we have 35 physicians and one managing physician and one administrator as well. So that's a lot of physicians to manage without a lot of time doing it. Now, our physician managers are responsible for seeing patients at least 7 hours a day. They get another half a day or 4 hours of administrative time. Sometimes they use it, sometimes they don't. Sometimes they're seeing patients. It all depends. But the point I'm getting to, or the point I want to make, is as physician leaders, you don't have a lot of time to mentor physicians, or as much time as you want. Does that sound reasonable? If you could have more one-on-one time, you would, but you don't? I would agree. So that's where the practice administrator comes in a little bit. We talked a little bit last presentation about it taking a lot of different people to mentor physicians or to work with physicians. Matt brought up a great example of his nurse manager just kind of, I guess, calling him out on the carpet on how he was acting at one point in time. So who's managing or who's mentoring these people? I think it's a little bit of everyone. And so we need to step up to the plate in operations, I think. I think you need to utilize your practice administrator a little bit more, maybe to see how they can help with some of the mentoring issues. And that'll all go back to, you know, this right here. You know, when you look at all these different tasks, there's a lot of different things that your practice administrator can help with. I want to talk about just a few of those, though. Number one for me is visibility. I'll talk about electronic visibility and what does that mean. It's easy to look at reports and see who's falling behind. At the end of the month, we see how many open charts everybody has, and if somebody is continually having a lot of open charts, maybe it's time to speak with them. They're going to get a letter from their chief or from our medical director. Just this Monday, we had a chief call me and ask me why a physician had so many open charts. And quite frankly, I should have known that before he would have should have called me. But in this case, it's a traveling physician who goes from clinic to clinic, so I went down and spoke with the physician. I just happened to be at the same site where this physician was seeing patients that day. Lo and behold, what I found out is, yeah, he did have a few personal issues. He had 2 teenagers. And if you've ever raised a teenage daughter and or a teenage son, it's sometimes not the most easy thing in the world. But I guess the point is, we had a great conversation about what was going on, and that afternoon, he had finished his records. I think all he really needed was someone to listen. And so that's very important. There's a lot that we can see electronically now that we're all monitored by every metric that we currently score. So I think, a comment was made earlier too, we kind of look over it and look over it and look over it. Well, I think if you keep saying the same thing, it's time to really do something about it, and your practice administrator is one of the best people that you have at your disposal, where you can maybe delegate some of those things to and have them watch out for any abnormalities or anomalies. Face-to-face, it's very important for our practice administrators to get out. You got to get out of your office, you got to get in the hallway. I can tell you, you learn a heck of a lot more in the hallway than you ever will anywhere else. And that's where I get most of my feedback when I'm talking to physicians or trying to interact with physicians and find out what's going on. A lot of times you're not looking for anything, but a lot of times you get things. Whether it's a problem with a colleague, a problem with nursing, a problem with administrative staff, no matter what it may be. Maybe it's the EMR. I can't do this, I can't do that. Well, let's let the practice administrator help with some of those, tasks. So you got to get off your butt. You got to get in the hallway. Let's talk about these are my typical hallway questions. I typically ask general life questions. Hey, how you doing today, Dr. Hall? Everything going okay? And if you do that routinely over and over and over again, you gain more and more trust, and eventually you start getting a lot more information than you ever did that first time. It's very important to develop that trust level with the physicians from a practice management standpoint. I typically sometimes go into nursing and then administrative support, clinic workload, EMR issues, anything and everything can come up. And I take notes. If somebody's mother's sick or their son is sick or something else is happening, I like to take note of that and then make sure that I ask them when I see them the next time. And when you can ask them, when you see them the next time, about how their family member may be doing, again, that just strengthens that trust even more so that they share more with you and so that you can help them. A lot of times this means, shuffling things up to the medical director or the managing physician or the chief. But I think with the limited amount of time that you have as physician leaders, if your practice administrator is not doing some of these things, then I think it's a good opportunity for them to kind of grow. But this is very important for me. From a critical skill set standpoint, your practice administrator has a bunch of those. We've talked about, let me talk about this. Administrative expert, but clinically intuitive. What does that mean? Well, we need to bridge a gap between practice administration and the physicians. The more a practice administrator can understand your practice of delivering medicine, the more intuitive he or she is going to be. Similarly, a lot of physicians don't understand all of the administrative work that has to happen, whether it's around reimbursement, payment structure, network development, whatever it may be. And I would argue the point that I think it's the practice administrator in a lot of these cases that needs to help bridge that gap. The more we can understand each other, the better off we're going to be. The more we're going to trust each other as well. Again, a lot of it goes back to trust. Knowing what to say and when to say, it's very important. Your practice administrator mentors a lot of different people. It's important to find out what makes people tick That not only includes their staff, but it also includes the physicians that they work with. And so, they are effective communicators. They're efficiency experts. They're coordinators of resources. If your physicians are having a rough time with completing their charts or getting through the day with Epic, what can the practice administrator do? I mean, the physician can help mentor them through this process. Well, this is how I do it. But your practice administrator can call on a lot of different resources, perhaps. Maybe you have an Epic team or an EMR team that can come out and assist the physician or shadow that physician and watch how they're managing their day. I mean, there's a lot of different things that your practice administrator can do. Matt did touch on this a little bit last presentation. They do a lot of different things. So these are just some mitigation strategies that I came up with. I mean, there's a lot more mitigation strategies than this, but talking about that hallway conversation, it's important to be out there every day as a practice administrator. It's important to be touching base, with your physicians. And showing up is half the battle. And I think if they see you, they'll learn to trust you as well. It's important to act. You need to listen. You need to be a good listener, and that's a lot of what a practice administrator does. But you need to take that information and act on it as well, including physicians in the decision-making process. Very important. And again, bridging the gap. A lot of these things, budgeting, finances, reimbursement, strategy. I can tell you, I sit through a lot of physician meetings. We have a monthly provider meeting, or every other month at all of our sites. And we go through a financial presentation, et cetera, and I can tell you there's a number of physicians that really don't understand the numbers. And so, it helps when we can put it in layman's terms and not just gloss over that, but dive into the detail and explain why these things are important. The more a physician may understand about some of these strategies, the more they're going to be able to understand their own practice and get through the day as well. I believe. So that's really it for my presentation. I kind of wanted to open it up for discussion, see what you think. Do you have any questions? This is a good time to ask.
Physician administrator partner is critical, I think, for the success of leading the department and helping navigate the matrix that can be complex at institutions. I'm intrigued by the notion of how little time the leaders get. And I'm getting to a question. How often do you, as administrator, meet with your physician lead? As an example, so me and my administrator meet for an hour every week, and oftentimes we meet more than that. The other thing that I did early on in the chair, in my chair role, is determine that one of the critical expectations for the leaders of the clinics and our respective shields, clinic or practice education research, was succession planning, and that takes time to develop the future leaders.
Sure.
So gave them additional time, up to a day and a half a week to do their leadership duty. It wasn't easy because access capacity is an insatiable beast. We'll never have enough of that. So I'm just curious how often you meet, and then how the time was decided that leaders would get to perform those leadership duties.
Well, I work with 7 different sites, and each one of those sites we have an administrator. And so I don't get as much one-on-one time with our physician leaders or the managing physicians as I want, to be honest with you. But I will tell you that I would want each administrator to meet with their managing physician at least weekly, for an hour each time. To be honest with you, it should almost be a daily interaction about what's happening in the clinic. The administrator is responsible for keeping that the managing physician abreast of what's going on in the clinic, whether it's a physician that's having a hard time compensating or completing work or whatever. To keep them updated on staffing issues as well, because those can bubble up to the top and then impact a physician who's going to then talk to their managing physician as well. So very important. What was your other question again?
How much does how much time is decided? Because it sounds like that oftentimes we get too caught up in the operations. So yeah, we meet when we need to, but that deliberate setting aside of time to help with strategy and succession planning, leadership development, et cetera. So I'm just wondering where in that spectrum the expectations for your leaders are. Is it more management, or is it really, you can be a future chair or future medical director, we need to work on your leadership, you need to be training your replacement, so to speak?
Yeah, we do have a, succession planning in most departments. Let me talk about that a little bit. And for instance, internal medicine, we have 3 associate chiefs. So our chief there has been able to delegate some of those responsibilities. I don't think you could ever have enough time to set aside to sort of work through some of these leadership issues and succession planning issues, but yeah.
So a question for you. So I've made some comments about administrators and whether they're empowerment oriented or command and control oriented. And it sounds to me, Stuart, very much like you've developed an empowerment and support approach to the work that you do working in the practices. So my question is, who trains practice administrators? A lot of practice administrators I was familiar with were MBA types, and they focused on the numbers, and in the fee-for-service world there's a pretty large amount of browbeating that happens around numbers, as opposed to what you're talking about. And for example, do practice administrators ever get a chance to go into a room with a doc and a patient to see what they do and how they do it, to help them understand the nature of the workflow for the doc?
Yeah, I think the old practice administrator was a back of the office kind of person. They spent a lot of time in the back office looking at numbers, working on things like billing and reimbursement, et cetera, et cetera. You ask the question, who's training this approach? And to be honest with you, I don't have a good answer for that. It's just it's the method that I've developed in my 33 years of management, because I've made some mistakes by not being out in the clinic, by not talking to the physicians, by just assuming things were one way and not another. So this is something that at least I impress upon my administrative staff, my administrators, to make sure that they're out talking to the physicians. They have got to be outward thinking and not inward thinking. You cannot, GOYB, which is one of the acronyms I have on one of the slides, is get off your butt. That's what it means. You need to get out of your chair and get in the hallway and start talking to people and find out what's going on, because that's where the rubber meets the road. And so many administrators or administrative staff tend not to do that. They want to sit in their office and manage the numbers. Well, you've got to manage the numbers, but you also got to manage the people. And again, you've got to find out what makes people tick, and what motivates them, and then work in that regard. Yes, ma'am.
Yeah. So at Ochsner, we have a dyad partnership, and we actually had a course where you had to attend the course with your dyad. So I thought that was a great way to form that partnership. But even after doing that with my dyad, she still didn't understand why we can't stay on time in clinic. So we had a project, and we said we're going to track this patient. And so she was on the floor in the hall, and she kept doing this. Like, why is he still in the room? I was like, this is real time. This is what, and it was eye-opening for her. And so even after having gone through the course, to be on the floor and to see what happens real time, it was a real eye-opening.
I'll agree. Sometimes we forget about the soft side of this profession. From a practice manager standpoint, where again, we constantly look at the numbers, but we need to understand. That's where I mentioned, we're administrative experts, but we need to be clinically intuitive. And you can't understand that if you're back in the office. You have to be out there understanding. It's easy to sit in a nursing station and figure out what's going on. And yes, there are different practice patterns. Every physician has a different one. Some are very concise, very clear, can actually have a short evaluation time where the patient thinks that they have been given anything and everything that they need. There are others that maybe ramble on, that take a little bit longer to get there. Everybody practices medicine different. And so, that's what's important, is for us to understand that and to work with that and try to leverage it as much as we possibly can. So, yeah, we have some classes, online classes. We have the Kelsey Academy, where there's some manager training, but I don't think a lot of that really speaks to what I'm talking about.
Steve, a question comes up in terms of the evolution of management structures, and we have a flattening of organizations currently in the current milieu of Google and other organizations where hierarchy is taboo, equality and team building is the model, and the youthful adults that are entering the workplace are striving toward that kind of structure. And we have, and I want to ask a question about what you think about moving in that direction in the conversation we're having right now and how that might work. Matt and I were having a conversation earlier about cultural issues. We were talking earlier about the shyness or whatever the cultural values are of family physicians, non-assertiveness. What was the terminology that we were using? Conflict avoidant. And so we have these, they're all kind of cultural issues that are coming at us at the same time. And I was looking at your slide that was talking about administrative expert, not clinically intuitive, or clinically intuitive. And I was thinking about, well, how about clinical expert and administratively intuitive? And how do we bring these various skills and attributes together in a less hierarchical milieu that actually begins to speak to the kind of organization structure that young professionals are seeking today?
Well, first of all, I'll say that the best decision is made at the lowest possible level, which I think speaks to the longitudinal or the flattening of an organization. And you're right, we have to bridge the gap. How do we bridge that gap? I think flattening the organization certainly helps. I mean, we've got to get out of our silos and start really providing team-based medicine. So, any thoughts from anybody else?
I don't have a thought, I have another question. Chip?
I think your comment about learning things over time, you talked about your career.
Okay.
You talked about your career and how you've learned, and I think that the same kind of process has happened as I've worked with the administrative people. Early on, the process was we would all go to a bunch of meetings, we would get stuffed full of stuff from our leadership, and we would come back to the clinic and try to stuff that into the people in the clinic. And
One size doesn't fit all.
well, it's almost like you need to catch up on your medical education, so let's go to 24 hours worth of CME, and you're supposed to remember it all when you walk out the door. It's very difficult to turn that into action. Like was being said earlier, you go to CME and nothing really changes because it's too hard to do that. And one of the things that I've done over the last few years is try to maybe stuff a chicken instead of stuffing a turkey. And coming to the office, we now meet twice a week for a shorter period of time, and we try to cover one thing. And before, when I was talking with the doctors, we would have a meeting once a month, and it was a very long meeting, covered lots of material, and by the end everybody was glassy-eyed. And now with the doctors, I meet with them twice a week, and we try to cover one thing that I want to talk about and one thing they want to talk about, and the meetings are usually 10 minutes, and they absorb it better, and they know that a couple of days later they can go over that same thing again. So they're able to have more fluidity about how we're working together instead of the traditional way, which has been very hierarchical. It's more conversational.
Yeah.
How do we work together with solving the problems? And then that gets carried back to the administrative part of it when we're having our administrative meetings. How can we work together on this one thing that the doctors have talked about? And it's more back and forth because it's more often and more casual.
Yeah, drinking from the fire hose really doesn't work all that well. You know, when you're out there and get an hour's worth or 2 hours worth of information, you know, get it in bits and pieces. I mean, that's how we typically learn better. So I would definitely agree with that. I don't know how many people actually use that format, but that's wonderful that you meet twice a week.
So I have a question about just operations and how you do it at Kelsey-Seybold, realizing that what you do at Kelsey-Seybold may not work in Dallas or New Orleans or wherever. But when there is organizational focus change, your CEO says we need to focus on whatever. How do you structure those messages? How much do you use distant, how much do you use video conferencing? And what has been the Kelsey-Seybold strategy for communicating those kinds of things?
I will say that the first rule of communication is know the audience. Who's the real audience, who's the intended audience, and how do they get the information? We use a variety of different, and John's going to comment on this too, but we use a variety of different methods. We do videos. Our CEO actually puts out videos, especially if we're going to make a huge change in direction. So, but I think you need to consider the audience first. Not every audience is the same. What method do they most like getting that information? For some people, it's video. We're all different. So, you know, I think again, it goes back to understanding your audience and how they like to receive the information.
So, do you mandate people read their email messages?
No. I'll be honest with you, I like it when I can get to an email and not even read it and just click delete, you know, if you want to know the truth. So we don't have any way of mandating or controlling, you know, what emails that people read. You know, our medical director, his name is Jim Hoyle, and he sends out a lot of emails, and so he's convinced that they see his name so often that they just hit delete. In a lot of respects, it's very hard, which is where the video message and really the on-site message too helps. You know, if we're having a significant directional change, you know, our CEO did go out and make a stop at every single site and every single provider meeting to talk about what we were going to be doing.
I think just to add to Stuart's comments, I think there's about 5 people that read, you know, the mass all user emails in our organization, probably not unlike any other organization here. You know, sometimes it's good to get out information to serve as a basis of understanding, but we rely heavily on our administrative team to pull that information, get with the managing physician, help communicate that, and if it requires a walk around so people understand what's going on or what that particular change is, then you know that's what they do. But if it's something less significant, less urgent, where the managing physician or the physician leader, irrespective of kind of where that is, you know, they can incorporate that into their next meeting, whether it's something weekly, monthly, whatever the appropriate frequency is, and we try to use that human communication. I think that, to me, is tends to work the best.
I think it speaks to what Jeff was saying too, and often, very often, we'll get, you know, there'll be a message that needs to get out. I will make sure, I'll send it out to our administrators and say, make sure this gets on your nursing meetings, your provider meetings, so that we can have a roundtable discussion on it.
Mercy, obviously, I 100% agree with you don't reach each physician the same way, that you need a smorgasbord. But we have 2 weekly emails that go out to primary care. One is primary care specific. It's called WHAM, What's Happening in Adult Medicine. My internal medicine vice president colleague authors that, and we take it. She authors it for the urban practices. We then take it, modify it if necessary for our regional practices, send the same thing out. That has a pretty high open rate, if you will. We have a organization-wide piece called Monday Morning that comes out on Monday morning, It's got about a dozen different short paragraphs with links to more detail, so if you see something in that that you like. We have also begun putting in that a lot of very provider, physician and APC focus items. You know, this is, I can't remember what the subtitles are, but basically we highlight one or two individual providers each session, and those get a lot of reads. I like to read about, you know, so what Phil Mitchell, you know, what Phil turns Phil on, why did he get into medicine, you know, what are his hobbies, why does he like Mercy? I don't think we asked him that question.
So the personal stories get through.
They get through. So those are two email things. Then we have monthly business unit meetings, we have quarterly regional meetings, and we have quarterly all provider meetings. So each provider has 3 to 5 opportunities per quarter to touch base with leadership at various levels and get various levels of information.
And we do much of the same, and you know, it works.
This is a good topic, and I think it shows that, you know, maybe as family physician leaders, we're, so to speak, all Christians, but we have different leadership denominations. And Pat Carter is a great person, if you know Pat, very effective. He came out of a military background. He has MBA, and his structure to me is military, where he delegates to the next officer, which is Stuart. And obviously Stuart's very capable, but I would challenge Pat to visit your regional clinics once a year for 45 minutes. I would challenge him. I relate more to this denomination where you have repetitive meetings. That's the only way I think you'll often get all the units working in tandem. Especially if you're in a big organization. Now, Kelsey Siebel is relatively big, but 65 family physicians, so it's moderate size. And then I believe in house calls as a leader, and Stuart's right, they have different personalities, and you know, I would encourage the medical leader to visit the sites much more frequently, because Stuart's right, they each have a different personality, a different subculture. And Stuart's doing a great job. And one of my, I have a list of homilies, but one of my homilies is, not that it's 100%, but never use administrative people to control physician behavior. And so I think you have to be careful with this, a little bit more hands-off leadership. But I think it shows that they have the right people in the right spot. Stuart is doing yeoman's work, I think. Pat's very good, as we all know. And his sites are maybe at a different level. That's just,
Good stuff.
I think it's a great topic.
You know, I really like how you talk about the administrative person walking the halls, and it's kind of a constant reminder. We try to do that where I am with the dyads. I think we can do a little bit more of them walking the halls.
It may be good to do them together sometimes.
Right. One thing we do is once a month we have what we call a gemba, where we go to each site, and they have a wall of work and just kind of what's going on at that site. Sometimes it's walking around the site, kind of depends on what you need to do. So I have 20 sites, and I see every one at least once a month because of that. It's a structured way to see it. It's only half an hour. It's not always enough, but it tells you if there's an issue there also.
Well, the more you're there, the more you develop a comfort level, or the folks there develop a comfort level with you, and the more you learn. So, you know, speaking again to frequency, it's very important to be frequent.
And
One
that-
Yep,
we do the same thing. We actually take our director, my counterpart, my dyad, out to the sites quarterly for an hour-and-a-half meetings, telling us what are you proud of, what do you need help with, and then it starts building a really nice relationship, and then we can say to them, well, you know, that other clinic is having those same issues. Why don't you two reach out to that other dyad? So it starts creating a community model that they have friends from across sites that can help each other.
Yeah, it's the same thing, the director, it sounds like exactly the same, half an hour every month instead of an hour and a half every 3 months.
Yeah.
And the other leaders can come too, which is nice, so they can drop in, it's nice, you have variety, I mean, it's always me, and there's always the associate department chair and the director and whatnot, but we may get other leaders there to highlight what's going on.
All right.